Hello everyone, I'm Dr. Swetha from Narayana Dental College. I'm here to discuss on a topic of jaw relations, that is mostly a troubleshooting jaw relations, mostly the MCQs. So, why I've selected this topic is that during my entrance preparation, I used to have difficulty solving the MCQs on this topic because most of the options are nearly close and seems to be very the correct answers. But mostly I used to go wrong in this particular topic. So I've tried to present the solution in as simple way as possible, only by knowing the definitions of certain jaw relation things. Okay, so without much delay, let's get started. So, what is a jaw relation? It is a maxillomandibular relationship, that is, a spatial relationship of maxilla to the mandible. It means that the mandible and maxilla is related in all the three different planes. Whatever, irrespective of the plane, it is related in all the planes, and we are capturing all this into a relationship. That is, in all the three different planes, we are capturing the relationship of maxilla to the mandible. That is nothing but a jaw relation. So, we have different three types of jaw relations. That is, in three manners we'll calculate it. One is the horizontal jaw relation, other is the vertical, and other is the orientation, as you already know. So the horizontal relation is the centric relation. Now let's get into it. See, the definition itself says many things about centric relation. See, once have a look at the definition. It's a maxillomandibular relationship. That means it's a relationship in which it is independent of tooth contact. Since we are not considering the tooth, here it is a bone to bone relation. Relation in the sense it's a bone to bone. Occlusion in the sense it's a tooth to tooth relation. Okay, so in which the condyles articulate in the anterior superior position. So whereas this relationship is establishing is it is a relation between the condyle to the cranium. Okay, that is at which place in the along the slides of the posterior slopes of articular eminence. Okay, in which position? It is in the anterior superior position. Previously, the definition used to be in the posterior most position. When you look into the books of Hartwell and Boucher, it used to be in the posterior most retruded position. But since the position is found to be the strained position, so or strained or unstrained, but the centric relations is always proved to be the unstrained position. So there is a slight change in the definition, and the more revised version of the definition evolved in the GPT 9 that it is an anterior superior relationship and anterior superior positioning of the condyle with respect to the articular eminence. Okay, and let's continue with the definition. The mandible is restricted to purely rotary movement. It means purely hinge movement. Usually the lower compartment of the mandible is completely related to the hinge movement, which is a pure rotation movement. That is possible only to a certain degree. Okay, so to 20 to 25 it is possible. And that particular position where it is relating in this position, that is called as centric relation. And this relation should be an unstrained physiologic relationship. Unstrained in the sense all the muscles which are keeping this relationship should be in an unstrained position. And also the patient can make a vertical, lateral and protrusive movements. That means it is the condyle is free to move in all the three different planes, that is protrusive, lateral as well as the vertical motion is possible. And here so we have got 5 different terms. One is where is the relationship established? It is in between the condyle and the posterior slope. What is the position? It is a anterior superior position. And how should be the muscle? It should be a physiologic as well as the unstrained manner they should be. Okay, and we are able to, that is the condyle is able to rotate freely in all the three different planes, and also only the pure hinge moment is possible. And there is a slight addition to this definition in GPT-8, that is at an established vertical dimension. This is very very important because I'll tell you why in the next previous slides. Okay, at an established vertical dimension, because in a vertical height is established, then only one should go with the centric relation, because for every established vertical height there is difference in the centric relation position. Okay, so if you calculate more, that is a 3 mm or 4 mm beyond the vertical height you have calculated previously, the centric relation changes according to the vertical height of the patient. Now coming to the physiologic rest position. This is somewhat similar to the centric relation. Don't get confused. Just go through the definition. It is a postural jaw relation. Postural in the sense it is dependent on the patient position. That's why the patient should be positioned in an upright condition. See, the postural relation when the patient is resting comfortably in an upright position and the muscles are in equilibrium and tonic contraction. In tonic contraction, equilibrium means every muscle is fired to the same resting potential. Okay, and the condyles are in the neutral unstrained position in the glenoid fossa. That is the relationship. It doesn't specify either it is anterior superior or posterior, but it is compulsory that the condyles are in unstrained position. It means rest, it means zero. So you can say the muscles should be at rest as well as the condyles should be at rest. This is only taken away by the muscles, and centric relation, the muscles has nothing to do with it. Even though the muscle is guiding its centric relation, but the muscle need not be in a unstrained position. But here all the muscles are in a unstrained tonic contraction or equilibrium position. Okay, and the condyles are in the unstrained position. So this physiological rest position is dictated by the muscle rest potential. So for every individual, the rest potential of the muscle is fixed, and it is fixed throughout the life. That is why, irrespective of the presence of teeth or not, the physiological rest position for the individual remains same throughout the life. It doesn't change unless until you will have a muscle pathology. So that is why when you establish a physiological rest position in a dentate patients or a dentulous patients, it remains same, almost same, and it is recordable and repeatable also. This is also called as the vertical dimension at rest. Don't get confused. This is a rest position, and the dimension that is established at the physiological rest position is a vertical dimension at rest. Usually in the vertical, which is called as VDR. Okay, vertical dimension at rest. In this position, usually what happens is the patient will have, in case of, I'm talking about the dentate patients, usually will have, if the position is if the patient is in physiological rest position, then the teeth will be slightly separated. You'll find a space that is called as a freeway space, which we'll discuss it in the later slides. But never ever this in the VDR the teeth will occlude, because the muscle, it has to be in a unstrained position. So since it is attaining the unstrained position, there will be a small amount of gap in the dentate patients. So that gap has to be replicated even in the complete denture also. So what happens if it is not replicated, we'll see in the further slides. Okay, see here the picture, it is depicting the dotted lines indicates the when the teeth are in occlusion, but the VD occlusion, that is a vertical dimension in occlusion, and rest is different. Rest, there is a space that is present 2 to 3 mm, which is called as a freeway space. Okay, and that position is called as a physiological rest position, and the height that is established is called as VDR, that is vertical dimension at rest. Now the vertical dimension of occlusion, it is the vertical separation of the jaws when the teeth are in occlusion or maximum intercuspation. You know what is maximum intercuspation? That is every cusp coincides with the corresponding grooves or the fossas. Okay, so in that case, if the vertical dimension that is established when the teeth are in occlusion is called as vertical dimension at occlusion. So we already told that in the VDR position there is slight gap. So what do you consider as more? VDR is more than VDO. So if you subtract the VDR minus VDO, it gives the freeway space, that is normally 2 to 3 mm. Okay, that is called as the freeway space. And there is one more point in this. There is another space that is also considered, which is called as freeway, which is freeway space discussed here. The other space is called as the Silverman's closest speaking space, that is around 1 to 2 mm, and that space is established when the patient is at speech while pronouncing certain sentences. You will find an active space present between the teeth, that is called as Silverman's closest speaking space. Don't get confused with the freeway space and the Silverman space. Silverman space is when the patient is speaking and it is around 1 to 2 mm, and in this space usually the muscles are active, not in unstrained positions, not in tonic equilibrium, that is not in resting potential, they are active, that means they are in contraction. Okay, so the difference between these two spaces is one is the active, one the muscles are active, in one the muscles are passive or rest position. So whenever the freeway space, so now you know the difference between the two spaces. So what happens if the vertical dimension is not established properly, or if you're increasing or decreasing it? How do you measure it? Usually you'll take a distance between the tip of the nose and the chin. Okay, that will give the vertical dimension of the patient. But if it is increased, which means you are encroaching on the freeway space, you are using up the gap between the teeth, that is supposed to be present, that is that 2 to 4 mm. So what happens, you are firing the muscle, you are not allowing the muscle to get into rest, so the muscle will be in continuous firing. So in order to overcome that obstacle, the muscle tries to resorb the supporting tissue that is present. So eventually it will lead to more resorption of the supporting tissues, that is the mucosa as well as the bone. So in that, and along with that, there will be some unpleasant sound in the dentures because of continuous clicking and premature contacts, and there will be exaggerated facial expressions, and there will also be facial distortion and difficulty in closing of the lips, difficulty in swallowing. So many things will happen when there is an increased vertical dimension. The same is also found with decreased vertical dimension. Here what happens, there will be overclosure in the occlusion. So you are not using the gap, you are creating excessive freeway space more than 2 to 4 mm. So there is no proper vertical height that is established, so there will be overclosure of the muscle. So in that case, the most probable, the first choice is the temporomandibular joint will get affected. So whenever an MCQ is given, the first choice is temporomandibular joint symptom is present, then you have to mark it, because the overclosure will mostly affect the temporomandibular joint first, and followed by the appearance where the chin appears to be very close to the nose, and the commissure of the lips turns down, and the lips usually they lost their fullness. Because of losing of the tonicity of the muscles. Okay, and mostly you will have angular cheilitis at the corners of the mouth. So now what will you see, you'll have in certain MCQs there are certain terminology which will be very confusing, so I've tried to put it up. See here, this interocclusal distance versus interarch space, mostly we'll get confused. Okay, this interocclusal distance is the distance between the occlusal rims or the occluding surfaces, that is the teeth in dentate individuals, and occlusal rims in complete denture patients or the artificial teeth. Okay, so indirectly the interocclusal distance is nothing but the freeway space. Okay, whereas the interarch space is the distance between the arches, that is from one ridge to the another ridge, irrespective of the presence of teeth or not, it is an interarch space. Is it clear now? So next, just look into the next point, that is this failure to provide adequate interocclusal distance or excessive interarch distance means the same. Failure to provide adequate interocclusal distance means you are not giving enough freeway space. Excessive interarch distance means you are increasing the vertical dimension. Both mean the same. In many of the MCQs I've seen that these two are used alternatively to confuse us. So don't get confused. Just think to the point. interocclusal distance is related to the freeway space. Interarch is something related to the vertical dimension. So here, failure to provide, that is inadequate interocclusal distance, means you are encroaching on the freeway space and you are increasing the vertical height. That's it. So okay, next, coming to the next point, which is an excessive interocclusal distance. It means interocclusal distance is a freeway space, so you are giving excessive, that means you are not giving the enough vertical dimension, that is you are decreasing the VDR. Okay, video, you are decreasing the vertical dimension at occlusion. So both of it is dangerous, but usually the book says that increasing is a bit better than the decreasing. Okay, so now coming to orientation jaw relation. So there are two terminologies which you have to know in orientation jaw relation. One is the hinge axis. So what is hinge axis? It is when the mandible opens and closes, the rotation occurs around a transverse axis. So the rotation will take place around a point that is called as a hinge axis. The plane is called as the hinge axis. So the rotation, we have already learned that in centric relation also there will be a purely rotation that is happening in the condyle. Okay, so if it is at the centric relation position, then it is called as a terminal hinge axis. Okay, and there is another terminology also called as transverse horizontal axis. Almost all means the same, but to be specific, if it is the rotation or the axis is calculated at, or the rotation axis is calculated in the centric relation position, it is called as a terminal hinge axis. Okay, what is transverse horizontal axis? It is an imaginary axis around which the mandible may rotate within a sagittal plane. The same thing, almost equal to the hinge axis, or hinge axis what we have discussed. It is nothing but if you are connecting a line passing from one condyle to the another condyle and calculating the rotating axis of the condyle in sagittal plane. That means mid sagittal is, it will divide the body into right and left parts, isn't it? So when you are calculating this opening and closing rotating axis in that plane, then it is called as a transverse horizontal axis. And when you're calculating it, you'll take the mean of this, and that is called as the transverse horizontal axis. So what is this orientation jaw relation means? You're orienting the mandible to the cranium. So you're transferring this transverse horizontal axis so that you are able to replicate the same moment in the articulator also. So the device which we use for this orientation jaw relation is the face bow. See here, you are recording this. You are trying to record this THA or the hinge axis, and you are trying to replicate it to the via the face bow transfer to the articulator, so that the articulator will simulate this axis, this kind of relationship where you will orient the maxilla to the cranium in such an angle. By indirectly knowing the THA is known as the orientation jaw relationship. Okay, see here, if you are mounting this to the cast to the articulator, the maxilla is oriented to an angle, so that angulation where it is oriented, you can't record it without a face bow. So in order to record it, we use a device called as a face bow, and this relationship in the patient is called as the orientation jaw relationship. That is how angulated it is to the cranium, that is maxilla, how it is angulated to the cranium, and how is this terminal hinge axis. So the main important device that is used is a face bow. So this is the face bow. You will have different face bows. Just get into it. See this flow chart, the face bow. If you know about the face bow, you will get to know about the orientation jaw relation completely. So it orients the condyle maxilla relationship, that is maxillary tooth condylar axis relation. Okay, so and it transfers it to the articulator. So there are different types of face bow. One is the arbitrary face bow, and other is a kinematic or actual axis face bow. There is not much of difference. Arbitrary in the sense you are calculating the hinge axis arbitrarily. Okay, so that is why it is called as arbitrary. It is not the exact hinge axis. If the kinematic face bow, it is the exact hinge axis you are recording and transferring. But in arbitrary, you are taking a arbitrary axis almost near similarly. So in order to calculate it arbitrary, you should have certain landmarks, isn't it? That is why you will have the posterior reference points and the anterior reference points. So this posterior reference points, usually we know what we'll read is the Behrens point, Bergstrom points. All these are this posterior reference points. That means they'll indicate where this caliper has to be inserted to record the arbitrary hinge axis. Okay. Whereas in kinematic there is no such problem. You are calculating the true hinge axis, so there won't be any problem. For this you'll have some pantographs, tracings, everything, so they'll record the true hinge axis in a exact manner. And in this arbitrary also, other than posterior reference points, you should also have the anterior reference point. There should be a 3-point standardization, isn't it? So in the anterior reference you'll have a nasion point, orbital point, all these things. Okay, so that is why in that also you'll have two types, fascia type and the ear bow type. In ear bow type you will get this ear bows which can be inserted into the external auditory meatus. So in that case you are able to record it in that position. The posterior reference is the ear points. And in fascia type there will be certain points, as I said, Behrens points or Bergstrom points, where you will mark it and then you will place the exact face bow in that particular position. So here there will be ear rods, in that the rods will be inserted near to that particular point. So that is the difference between an arbitrary and kinematic face bow. So usually in all the complete denture cases we'll use the arbitrary kind of ear bows only. So look into this picture. This is a ear bow, that is the posterior reference points is into the external acoustic meatus, that is ear rods are inserted into it. And the next, this is kinematic bow. What we are talking is the exact kinematic location is captured here. Other than this, there will be another condylar rods will also be there, where the posterior reference point will be the condyle or the Behrens point, which is 13 mm anterior to the outer canthus, line between that. There you will insert the condylar rods. Same like what I have shown in the previous picture, the ear rods. Instead of that, you will call there, it is called as a condylar rod. Here this is called as a kinematic bow, where see the difference you can appreciate it. In the kinematic phase bow, this bite fork will be inserted to the mandible, the clutches will be inserted to the mandible, whereas in arbitrary it is positioned to the maxilla. The only difference which we could make with the picture is this one. The kinematic is more precise, whereas this arbitrary, it is not less precise. Okay, so that is why we'll use it in complete denture cases, arbitrary cases. Okay, so by now you should be thorough with all the definitions. It almost covers the entire topic, but there are a few questions that are present in the topic which are very vague. So after knowing all this, one may get a doubt, which is the first one you'll do in a jaw relation. First, always orient the jaw. Orientation jaw relation is the first thing. That is, you have to orient the maxilla to the transverse hinge axis of the mandible, or the maxilla to the cranium. Either way it is correct. Okay, after orienting or angulating at a particular position, then you have to establish the vertical jaw relation, that is the rest position. And after that you have to go for the centric relation. Why is that? How to remember it? Because in centric relation it is given at an established vertical dimension. That means you are supposed to do a vertical dimension before the centric relation. If it is not established, then for every vertical dimension increase there will be change in the relationship, centric relation. So that is why you are supposed to do a vertical jaw relation before to the centric relation. So the sequence is orientation followed by vertical followed by centric. So this almost covers the entire MCQs in the jaw relation topic. So as we completed the topic, now let's troubleshoot it. So here are a few MCQs. The first one is hinge axis face bow records. Relationship of teeth to the axis of rotation of the jaw. So this may be a correct, but see the correct answer is 1, because you are supposed to relate the maxillary teeth or a maxilla to the THA or the hinge axis of the mandible. That is the thing we have learnt. But see the second one, you may have a doubt with other two options. Relationship of mandible to maxilla or maxilla to mandible, which is a centric relation. So that can't be correct. Third one is relationship of mandible to cranium. How can you relate a mandible directly to a cranium? THA is relating mandible to the maxilla. So maxilla, you are relating it to the mandible. So in that case, the first option, that is relationship of teeth, that means a maxillary teeth to the axis of the rotation of the jaw, is correct. So by knowing the definitions itself, you are able to solve this. And so the next MCQ, the interarch distance measured when the occlusal rims are in uniform contact is. Usually when you have an interarch distance or interocclusal distance terminology, we will usually get confused with the freeway space or something like that. You'll first mark the freeway space, but just read carefully the interarch distance, which means the distance between the two ridges, as I said. So two ridges in the sense it is giving the height. Okay, so and look into the clue that is given in the question. Measured when the occlusal rims are in contact. Contact means occlusion. So the height at occlusion. Indirectly, the question itself is giving the answer. That is the vertical dimension of occlusion. Okay. So the next question. Most accurate reproducible relationship for recording jaw relation. One is physiological resposition, centric occlusion, centric relation, all of the above. So it is jaw relation. Never ever he has mentioned about the teeth. So it can't be a occlusion. So it is not centric occlusion. And it is in between centric relation and physiologic. Centric relation is a point which is repeatable and reproducible, and from which all the motions are carried out easily, like vertical, lateral, protrusive. So in that case, it should be the answer. Centric relation is the answer. Most accurate reproducible relationship. Okay. So next is only pure hinge moments of the mandible occur at. So moments nothing to relate with centric occlusion. So first option, centric occlusion, is ruled out. Second option, centric relation, lateral excursions. Lateral excursions is ruled out because in lateral excursive or eccentric moments, always there will be translation followed with rotation. So both will be there. So that is ruled out. And second, centric relation and terminal hinge position. It can be both, because in centric relation also pure hinge moment is present. But if it is given like only pure hinge moments of mandible, the first to go with this terminal hinge position if it is given. If there is no option telling you about THA or hinge axis, then you should go with centric relation, because that is the sequence we are following. First is orientation, vertical and centric. The same way, if the option is given like this, if the question would have been pure hinge moment of the condyle is present at a position, then it is a centric relation. Okay, so the answer is terminal hinge position. Next is centric relation is between a maxilla to cranium, mandible to cranium, mandible to condyle, tooth to tooth. So tooth to tooth can't be the option. So mandible to condyle, it is in the same jaw, so it can't be option. Maxilla to the cranium, maxilla to the cranium is orientation jaw relation, and mandible to the cranium, how is this option given? Just look into the definition here also, the basic. What is given in the definition? It is a condylar relationship along the posterior slopes of articular eminence. Articular eminence is related to the cranial part, so that cranium, base of the cranium. So that is why he is relating the mandible to the cranium. That is indirect option. So you have to rule out the options like this in every possible questionnaire. So here's the end of all the troubleshooting issues. Only a few of them are discussed here. So I hope you understood everything. And sorry, one last question. Facebook measures relationship of maxilla to opening and closing axis, mandible, zygomatic bone, none. So now it is very clear, it is THA. Whenever a THA is given, that is opening and closing axis, then it should be marked. Okay, Facebook measures relationship of maxilla to the opening and closing axis. So now it's clear, we have dealt with all the MCQ parts. Only few of them have been dropped. So thank you for your patience listening.